Good morning, everyone. I am Dr. Mohit Agrawal from the All India Institute of Medical Sciences at Jodhpur. Um, I am an associate professor of neurosurgery and an epilepsy and functional surgeon. So, thank you so much for this invite and for being kind enough to listen to me on a Monday morning. My talk is essentially use of 3D volume rendering technique for intraoperative localization. That is a poor man's neuronavigation. I'll just 1 second. Yeah, I'll just go ahead. A little bit of background about where I did my residency from. I did my residency from one of the biggest centers in India, that is AIMS, New Delhi. The department was established, one of the first departments in the country. And over there, we have everything. We have the ROSA, the robotic microscope. We have all endoscopes. It's one of the largest countries in one of the largest hospitals in India. So from there, after I did my fellowship, I moved to this All India Institute of Medical Sciences, Jodhpur, which is another institute in the western part of the country. You can see with this star mark, it's a tier two western country in the western part of the India, predominantly rural population, and we did not have any high-end equipment at outset. So, so we knew from my experience that accurate intraoperative localization is essential for safe microneurosurgery. But how to do so if one does not have any high-end equipment like neuronavigation? So, with this background, we see that the conventional localization of any brain tumor or any lesion is basically based upon the Taylor-Horton lines, which have been beautifully given by our previous neurosurgeons, and the surface anatomy, which is by the gyri and the sulci, and that this is what we essentially the patient brings to the OPD, to the clinic, a CT or an MRI, which we then reconstruct in our mind. We try to reconstruct this tumor in our mind and try to devise a way by which we can approach the tumor safely and resect it safely. So this is easier said than done. Of course, it has a lot of fallacies, and there can be many issues with localization just on the basis of this CT and MRI. So what are the solutions that we have come up with? We have come up with navigation tools, which are again expensive. They are not easily available to everyone, and then it increases the OR time, and then it puts you at risk of hardware malfunction. If the hardware malfunctions, you don't really have anything else to fall back to. Then ultrasound is relatively cheaper, but it does not help with the planning of the craniotomy. It also has a learning curve once you start getting to use it. Intraoperative CT and MRI, of course, cannot work without a navigation, and also a lot of issue with accessibility and cost. So essentially, what does navigation do? We have to first see what basically neuronavigation does. Neuronavigation allows the co-registration and transfer of the pre-operative imaging data into the surgical field. That is the physical space of the patient, of the head of the patient. So, what if the traditional surface anatomy teaching methods like the Taylor-Horton lines and the utility of navigation could be combined in a replicable manner? That would really be helpful for someone who does not have navigation, or you are operating in an emergency OR, in an emergency situation where you don't have access to navigation. So, what is volume rendering? This is where volume rendering comes in. It is basically a type of visualization technique wherein a stack of 2D images are regularly spaced 2D images are then converted into 3D using the VR technique. It is all done by the software. It is clinically very valuable and it is easily available. There is lack of awareness regarding the softwares, and there is a certain amount of learning curve. So these are the three most commonly used softwares: Osirix, Horos, and Radiant. And today I'm going to talk about Radiant, which we have found to be very intuitive and has a relatively uh, easier learning curve. So, what are the prerequisites for obtaining the 3D VR images? It's pretty simple. 1 mm contiguous non-overlapping cuts are required, and any CT or MRI in the DICOM format. Flare images, as you will see, are best to see the surface anatomy, like the gyri, sulci, and non-enhancing lesions, and contrast images for the veins, arteries, and the contrast enhancing lesions. And all you need is a computer running Microsoft Windows 10. That's it. So this is the typical workstation wherein the images are displayed over here, and there are various tools which you can play around with. There's a 3D VRT icon over here and a 3D MPR icon over here, which I have actually pointed out. So what are the clinical use cases scenarios? First of all, what's the use in cranial trauma? So an extradural hematoma is the most common, probably the first surgery which a new resident gets to do in his or her career. So as you can see, this is an extradural hematoma on the left side of the patient, on the over the left temporal lobe. Its distance from the zygomatic arch is around 4 centimeters. But as you can see in the post-operative CT scan, the craniotomy has been made in a completely different level without even exposing this part of the temporal lobe where the hematoma actually was. So we analyzed this using a 3D volume rendered scan. So the actual craniotomy should have been somewhere around here, 4 centimeters from the root of the zygoma. But what the resident has ended up doing is making a craniotomy over here when it should have been over here. The incision which was planned was over here, while it would have been better if you would have planned a curvilinear incision like this and exposed just the temporal lobe. So visualizing on a 2D CT scan, the exact craniotomy required for the temporal lobe can be sometimes be difficult. So what we do, this is where the utility of the uh, 3D VR comes in. So this is another right-sided temporal EDH. I'll just demonstrate how do we use this technique. So you just make a 3D VR of the CT image. Using this button, you can adjust the images. Then this cut tool comes in, wherein you cut the tool in half. You cut the images in half. So as you can see, I've exposed the right side of the cranium. Now using this windowing tool, this extradural hyperdense hematoma comes into view, which you can again cut. You can rotate the image. Once you have rotated the image, the exact site of the hematoma with relationship to the bones comes into view. Now, once again, using the windowing technique, now you can clearly make out the extent of the hematoma with respect to your surface landmarks. So this is a kind of personalized surface marking of the hematoma, which has been done on the patient's skull. So I'll just move on to the next slide. Another example wherein there is a left frontal hematoma along with a overlying skull fracture. So using just this 2D images, it might be difficult to for a new person for a new resident to reconstruct this image in his or her mind. So which is easily done once you do a 3D reconstruction. You can exactly make out the extent of the fracture, its relationship to the corneal suture, and then again, once you cut the images and use this windowing tool, you can again make out the exact extent of the hematoma, the exact extent of the extradural hematoma. Its relationship from the inside to the corneal suture, whether it is extending to the orbital base or not. So, and you again rotate the scan, its relationship to the corneal suture, relationship to the midline, And it's also, once you use the windowing technique, it's exact relationship to the nose, to the any of the external, commonly used external landmarks which you might see on the patient's head while planning a craniotomy. So coming to low-grade cortical gliomas, wherein you use a 3D FLAIR imaging. So I'll just go back. So this was a low-grade glioma involving the pars opercularis. So this is the pars orbitalis, triangularis, and opercularis. So we take the 3D FLAIR imaging, we convert it into 3D, and then again using the windowing technique, which you will see in just a minute. See, you can clearly make out the surface glioma standing out very well on this 3D image, and you can exactly make out the cortical and the sulcal anatomy around it. Once you have cut the lesion, again, its exact relationships or its exact personalized surface marking of the glioma is available to you with respect to the pinna, with respect to the outer canthus of the ear of the eye, and you can exactly plan out a small localized craniotomy in this manner. So, what about contrast enhancing lesions? So, this is a preoperative MRI of a ependymal lesion. So again, converting into the 3D and using this windowing technique. So if you pay attention while windowing it, you can clearly make out the surface veins as well. Although not relevant to this case, but you can make out the surface veins as well. Once you have delineated the lesion, mark my words, this is a deep-seated lesion. So deep-seated lesion and its exact relationship to the surface anatomy can be easily be made out, which will help us in studying the surface anatomy and deciding where we want to enter the lesion. So this is the intraoperative picture. You can take a printout of these pictures and take to the OR, and following which this exact with a small craniotomy, this tumor can be excised. So this video was actually published in Neurosurgical Focus a couple of years back. You can check out this publication. It's open access for all, and wherein we've also described how VRT is useful for the surface cortical veins via these two examples. So the exact surface cortical veins as a surface cortical anatomy can be made out, and a safe corridor to the tumor can be visualized. So coming to the last use case scenario is a focal cortical dysplasia. So I'll just skip this preoperative evaluation, wherein the focal cortical dysplasia was localized to the left frontal hemisphere. This was the EEG also showing a left frontal spike. So this was the T2 hyperintense, the FLAIR hyperintense lesion, which was just adjacent to the motor cortex. And what is essential to see is that it is a T2 FLAIR hyperintense lesion. I'm sorry. So again, putting it into the same software, you utilize a 3D FLAIR scan, and we utilize this FLAIR hyperintensity of the lesion for our intraoperative localization. So you can just rotate the scan wherever you want it to be. So this is how it appears initially. So don't be too hasty to dismiss it, because once you window it properly, then only you can make out the exact cortical anatomy. You need to play around with it a bit, because initially finding this exact amount of windowing for you to be able to see the sulci and gyri sometimes can be difficult. But once you play around with the software, it becomes quite easy. So our lesion was FLAIR hyperintense. So once you keep on windowing the scan, you can clearly make out this hyperintense lesion over here, this U-shaped hyperintense lesion over here. So once you have made out the lesion, you again window the scan back to the surface anatomy, and now you can make out the exact relationship of the lesion to the normal cortex and the normal gyri around it. So what you do is you cut the lesion, and once you have cut the lesion, we can again make out its exact relationship to the surface landmarks. And this was what we found intraoperatively, this U-shaped lesion, which was excised in toto. So at 36, this was the post-operative MRI showing a focal resection of the entire lesion, and the patient is now seizure-free. So again, a second case wherein the lesion localizing to the right frontal hemisphere, showing a thickened gyri, which is again hyper intense on FLAIR imaging, and transmantle cell can also be made out. Again, this lesion localizes using the same technique, the lesion localizes to this inverted U-shaped gyrus, to this lesion, and we see a inverted U-shaped gyrus, which is normal and adjacent to the lesion. So this entire focal cortical dysplasia was resected, and this U-shaped gyrus, which is normal, which was our marker in the preoperative MRI, is preserved. Again, the child is seizure-free for the past 2 years. Again, third use case scenario wherein our 3D VR was actually helpful in localizing the lesion intraoperatively and also seeing whether we had an adequate exposure or not. So again, making out the lesion, that this is a lesion which is exact next to the fox, and there is a opposite S-shaped gyrus which is adjacent to the lesion. So intraoperative course correction, because there was big medial venous lakes which were obstructing further exposure. But we know from our preoperative anatomy that the lesion is present medial to this S-shaped gyrus, which you will just see in a minute, this S-shaped gyrus. So we have to go a little bit more medial somehow and resect the focal cortical dysplasia. Again, the child is seizure-free for the past 24 months, and we see a very beautiful focal resection of the lesion. So perirolandic lesions, this hyperintensity is the lesion, and you can make out this T-shaped gyrus which is overlying the lesion, which we have to again go in and resect. So these are the intraoperative pictures and the post-operative scan. So you get the main gist of the technique. So again, another case. So what I would like to say is that the conventional MR images are like our conventional maps, which we used to have initially. And volume rendering technique is a easily visualizable roadmap, like the Google Maps. So, like Google Maps takes you to and it shows you the exact way to reach your destination. So that is how you see this volume rendering technique and use it in your day-to-day surgery. You might have navigation, but this is always good to have as a backup. So we have, over the past few years, we have published numerous publications using this 3D volume rendering technique. And this is our head of the department, Professor Deepak Jha, who actually taught us this technique when we joined the department. And if you search his name on PubMed, you will find numerous use case scenarios of this technique. And this technique is not like we have developed this technique. It has, over the past decade, there are several publications from Brazil, from Bulgaria, and from various other centers utilizing these Horos or Osiris and doing this virtual preoperative planning. From Turkey, Professor Ture. So what's the take home message? So no technology can or should replace your knowledge of surgical anatomy. That is paramount to have. No navigation or intraoperative MRI can ever replace your knowledge of surgical anatomy. VRT, it actually gives you a way of personalized surface marking. It enables visualization of the brain in relationship to the surface anatomical landmarks. And you must be thinking that this is a very easily replicable solution and it's quite simple to do, but always, and the most easily replicable solution is always the most useful. Don't need to complicate your life unnecessarily using navigation and MRI, and don't let ever anyone tell you that you don't have this high-end technology, so you cannot operate, you cannot do a localized or a uh, beautiful technique to resect your tumors. So, in the end, I would like to say that VRT as a navigation tool is easily accessible, accurate, and useful in resource constrained settings. And there's a large burden of patients who should not be denied surgery due to the unavailability of this expensive equipment. So it's always a team effort. We wouldn't be here without our professor who taught us this technique. It's always a team effort. So thank you so much for listening.